Okay. Alrighty. So today we're gonna go through PVD, just PVD. You can do ortho on Sunday. That'll probably be a shorter one because your ortho is more mostly review. There's some stuff in there that's new. Mainly probably just like the osteoarthritis or focus osteoarthritis and it has to do with like the hip precautions and stuff. So we'll cover that on Sunday instead. Okay, so with PVD here, I kind of wanted to just go over the risk factors first. So what do you guys think about some risk factors that would cause PVD? And then I want to also talk about that it's kind of an umbrella term. Well, um, yeah, sure, smoking can cause it, hyperlipidemia, it's a prey. That's with hyperlipidemia, for sure. Atherosclerosis for sure. Um, The varicose veins is kind of like a sign of it almost. With chronic venous insufficiency, your varicose veins is maybe like can be seen as like the very start of it. Hypertension, yeah. I think the only other thing that maybe you can include is maybe like age above 60. Um, Kind of a sedentary lifestyle, so lack of exercise stuff. So a lot of the typical stuff, obesity, yeah. A lot of the typical stuff you see with a lot of your perfusion based stuff. So it'll keep coming back. Over time, you'll just immediately start thinking about all these things for perfusion based thing. They'll kind of come together. Okay, so now your PVDs, like I said, it's an umbrella term. So it consists of two different things. What are those? You know, each individual one. Per- Peripheral arterial disease, also known as PAD. And what's the other one? Yeah, peripheral venous disease. Does not really have shorthand. So PVD, when people say PVD, they're actually referring to peripheral vascular disease. But peripheral venous insufficiency or peripheral venous disease is not shorthanded as PVD typically. Maybe I'll make this text a little bit. Okay. So yeah. Okay. So here we'll talk about peripheral arterial disease. So what's it caused by? So again, we're just gonna go through some quick and dirty patho, just quick, and maybe you guys can do the definition because they're both. What's like the number one cause of PAD and how would you define it? So yeah, so Fidel, yeah, so it's caused by a atherosclerosis. This is like your big thing with this one. And Theron says it's the ischemia, lack of O2 reaching the extremities, tissues, muscle. You can simplify it a little bit. You can kind of think of it as just difficulty perfusing um, to lower extremities is usually like a little bit of a more simple term. Effectively, your peripheral arterial disease. Remember, your arteries are the ones that send blood, where the blood is going to travel to away from the heart and into your other tissues to perfuse them. So a lot of time, if you're having issues perfusing through the arteries, it means you're going to have issues with typically it's going to be your lower extremities because that's the farthest place away from your heart. You're going to have a difficult time getting the blood that they need. But you're not wrong. It is going to cause ischemia, lack of O2 from reaching those extremities, tissues, etc. So this leads to um, ischemia. Um, okay, and there's definitely some major differences between the PAD and the peripheral venous disease, and we'll go through them. And then afterwards, I'll give you guys kind of like a little table, kind of like I've been doing with some of the other ones, just like a table that directly compares and contrasts both of them. And so kind of like when we talked about MI and hypertension, all that stuff, what are some consequences of PAD? Arterial ulcers. Yeah. Do you know what the pain during activity is called? Yeah, the claudication. Um, Name of it. I think you guys probably saw there's like a Kaplan question where they use the actual name, they use claudication. They just know the names of all that stuff. What else can you guys think of that? So ulcers, the claudication pain. So think about some general consequences with perfusion issues. You can have gangrene, gangrene necrosis, put together, neuroarterial ulcers. I remember just clustering. So yeah, you can also have resting pain. So that's resting pain is when you have a later stage of the AD, pain or activity, and rest. What else can you guys think about? Think about generalized perfusion issues. So if you're in general, if you are having issues getting blood out of your body, out from your heart to the rest of the system, what do you guys think? What you guys said you might have some. Think about like really big consequences. Like think about your typical perfusion-based consequences. You can even go back and think about your hypertension. Think about your hypertension consequences.
Tachycardia.
That can be one thing. That could be something that you will have, like as a compensation. But I want like more hard-hitting consequences. Something that would bring someone into the hospital. So someone said called, yeah, cold and models, we'll put that as a manifestation. So the cold model legs. Someone mentioned, yeah, weak pulses, that'd be like a manifestation. Someone said shock. I'm sure that could happen in powder. You guys are listing right now, you guys are listing a lot of manifestations, which is good. Delayed healing for sure. Right now, I'm just looking, what else can you guys think about that would bring someone into the hospital that's related to perfusion? DVT, yeah. So DVT is more associated with a different one though, because remember DVT, what does the V stand for in DVT? That's venous, yeah. So not so much for the PAD. Um, but again, what is a perfusion-based thing that can bring someone to the hospital? Again, some of your consequences for an MI, but for some of the consequences for hypertension rather. So stroke, yeah, stroke and MI basically is what I was looking for there. I also have stroke and angina. So some of these like acute coronary syndrome. Remember, what is your main cause of it? It's atherosclerosis. So between atherosclerosis and having this issue perfusing, you can have pretty much the same consequences as that. So remember, just keep in mind that all these things become really interconnected. So remember all these same risk factors. So pulmonary embolism would be something that would be more associated with the venous, because if you remember, your pulmonary embolism a lot of the time can come from a DVT. So when a DVT manages to get back up to the heart, because it's from the venous. So remember your venous. Blood from the venous is going to turn to the heart. So it's going to come in from the right side. And then when the right side of the heart from the ventricles goes to the lungs. So that's how that kind of goes. So the DVT, you have clot in venous, turns to right side of the heart, and gets stuck in large arteries or vessels. That leads to a pulmonary embolism. So remember your blood flow of um, how that goes down. So DVT is a clot in venous. If it manages to get dislodged, it'll go back up to return to the heart. Then that gets pumped out to the lungs, and if it gets stuck in a large lung vessel, you can get a pulmonary embolism. And not every clot that manages to make itself to the lungs becomes a pulmonary embolism. Typically, with your pulmonary embolism, it's like a big clot that gets stuck in there and causes huge issues. Um, Sometimes, like a small clot can make its way in there, and because your lungs have so many capillaries and stuff, if it's a smaller one, if it gets stuck in like a tiny capillary, and you don't end up having like a large amount of damage. So sometimes, like a tiny clot can actually just get stuck in like a tiny lung capillary and dissolve itself, or gets dissolved without causing anything. So sometimes your lung capillary system can kind of work to deal with like tiny clots. If those tiny clots somehow manage to make their way through, then we can think about stroke or MI, but that's why your DVT is more likely to cause PE rather than like a stroke, because for a stroke, it would be that clot would have to both make it back into the heart, make it through the lungs, and then get pumped out to the brain, if that makes sense. Which is why a DVT is typically going to cause PE rather than like a stroke or an MI. Does that make sense? Am I confusing anyone on that? Anyone understand what I mentioned, or do you want me to explain it again, or just move on? Make sense? Yeah. Okay. Yeah. So again,
Could you
DVT.
explain it one more time?
Yeah. So basically, kind of like what I wrote there. Your DVT is more likely to be cause of pulmonary embolism because it's going to get stuck in the lungs. And it's much less likely that it causes a stroke, because for it to cause a stroke, it would have to go all the way back into the heart, go through the lungs without getting stuck on a capillary somehow, and then also then come back to the left side of the heart, get pumped out from the left ventricle, make it all the way to like a brain artery, and then get stuck. So that's why it's so much less likely that DVT causes anything other than a pulmonary embolism. Does that make sense? It basically has to go through way more, and it's less likely.
Yes,
Okay,
thank
but
you.
mhm. Um, But when it comes to like arterial things, so clots in the arterial, because if you have a clot that's starting out in the arterial already, then it didn't have to go through the lungs, it didn't have to go through anywhere else. So then that's when those are going to lead to strokes and MIs more likely, because if the clot is starting out in the arterial, it didn't have that chance to get stuck in the lungs. where it might have caused a pulmonary embolism or where it might have just gotten stuck in a tiny capillary if it was small enough and just kind of died out on its own. Uh, yeah, so something that I guess if it's interesting for you guys to learn, there's like some things with like pediatrics that you guys will go over when you guys get to 222, where like some people are born with like a little hole in between their heart, and then um, sometimes if like a clot, like a DVT, might actually go through that hole and kind of skip the lungs to get to the left side of the heart, and that's when you start having issues with that. And then when you have AFib, you remember your AFib, your atrial fibrillation. Sometimes because of the atrium fibrillating, you get clots forming inside of the heart that then get pumped out to the artery. So that's why your AFib is more likely to cause stroke than anything else, because the fibrillations can end up allowing kind of clots to get pumped out from the like starting in the arterioles rather than venous side of it. Just extra information, but just kind of trying to paint the picture with that your arterial disease is more likely to cause this stroke and MI because of the location, um, and just because of that pathway that that it gets to skip essentially, unlike the DVT, which has to make it through the lungs first. And that's not something you guys have to like be experts on, but it's just kind of like information to try to paint the picture and try to get more context on how the stuff, how why the things are the way they are. But yeah, so you guys mentioned a lot of good manifestations, so that's great. Is there anything else you guys want to add on to the manifestations of PAD? Thin scale, yeah. So yeah, hair loss and thin scaly skin. Because if your legs and your lower extremities aren't getting perfusion, that means they're also not getting oxygen and they're not getting nutrition as much because they're not getting as much blood. So it means that your body doesn't have um, enough resources to have smoother skin, doesn't have enough resources to have hair going on. It says no elevation. Um, like edema, you mean? Like no edema? Is that what you're referring to by elevation? Oh, I know what you're referring to. You're referring to like interventions. So that's something we can add here. So cutting a little bit ahead, yeah. So elevate the legs. And why is that? Why do you think that is? Yeah, yeah, exactly. So if you were to elevate, then the blood is going back to your core, which isn't actually the problem in PAD. The problem with PAD is getting the blood to the legs. So you'd be doing essentially you'd be hurting them in that case because you'd be making it even harder to get the blood over there. Okay. Yeah. So Caleb mentions positioning. You want to do some dangling. Yeah. So you want to do dangling to bring the blood to the extremities. Gravity. Yes, exactly. That's called a dependent ruber. That's the color that their legs get. So when you do dangle them, you can see their legs get a bit kind of reddish because the blood is kind of flooding back in. So something else I guess I might add for manifestations is there's not really going to be edema. So when we think about patients with venous insufficiency, they get a bunch of blood pooling in their legs, so it ends up leading to them having edema. Um, but in this case, the blood isn't even getting to the legs as well as it should, so there's no edema, as opposed to as opposed to venous insufficiency, where there's pooling of the blood in the legs, right? here the stages of PAD. So there's like a few stages um, on how bad the PAD can get. So I think for this one, some shiny skin. Let's see. Would you have shiny skin for manifestation? I'm trying to remember that one. I feel like it wouldn't be. Let's see. Alexis linked something for lecture. Let's see. Guessing that's like a direct comparison picture. Yeah, that should be helpful for sure. That's a really good picture. So let's see if I can include it in here. And I'll kind of just include it at the bottom. Perfect. I'll include that one for you guys. You have access to it with the PDF. But right now, I just want to talk about the state. I want to make sure we have time for everything. And again, I don't think you really have to, the focus isn't too hard on knowing every stage exactly, but I'm just here to paint you're here. So with stage one, you're more likely to be asymptomatic, like Kayla mentioned. The pain isn't really going to be there as well. You might start having some decreased pulses and stuff. So some things like that. Let's see, it's hard to detect. Yeah, it's pretty hard to detect because it's asymptomatic and you have a lot of things that mimic it come out differently. Stage two, that's when you start having a bit more of the claudication, the pain, muscle cramping, burning. And I guess the one thing that would be good is how would you kind of see if someone has claudication? ABI is what we would do for diagnosing the condition, but what about the claudication? Pretty much just have them exercise, have them walk. You can do a stress test on like a treadmill or something. And then once we get to stage three, that's when you start having claudication, even at rest. And yeah, someone mentioned it too, but it kind of has a bit more of a numbness at this point. Um, Numbness and dull pain. Okay. And stage four, as it gets even worse, that's when you start having some cyanosis. You'll start having ulcerations, necrosis, gangrene, and more likely to have amputation here. Okay. And ulcers, was like one word that really gets used to describe the type of ulcers that happen with PAD. You guys remember what it's called?
Is it the punch hole ones, the arterial ulcers?
Yeah. So these arterial ulcers are called the punch out. They're little punch out wounds. You can get a for that. Um, yeah, there's very little edema, very little drainage. Because remember, we don't have much blood flow out there. So there's really not much else going on there. It's just no drainage. It's dry, airless, uh, all of it due to blood in between the toes. Yeah, kind of, yeah, pretty much. Gonna post a picture. This is like a I have showing some of the leg ulcers, so you just kind of have an idea of what they look like. It comes attached with some diabetic foot ulcers and pressure ulcers, but here you can see kind of the difference here. So these are arterial ulcers versus this venous ulcer, where you'll see um, the skin is going to have a different color, so much blood pooling, while arterial ulcers are the we were saying little punch out. So we'll look at one. Yeah, here, let's see if we can do arterial ulcers. One that looks like very good. Picture isn't here anymore. That's funny. Yeah, on there. Okay. Mm, let's see. Wait, pretty bad. In there, like that. I guess you can see again. It just looks like I just took a little punch out. It's like a little hole, and just kind of opening up. Stuff. Um, is there any questions so far on anything that you want to go over a little bit more? It's gonna be. Let me double check on if that it's actually gonna be more painful. Yeah, it's gonna be more painful. So kind of like the same idea for the that you have pain with walking. You're gonna have pain from the lack of oxygen flow. So just like how your heart, you have chest pain with ischemia, you're gonna have pain with the ischemia on the arterial ulcer, but the venous ulcer is not really gonna have much pain going on because it's got so much blood flow going on. So there's still like the venous ulcer is still kind of like actively healing to some degree. So I think you mentioned here granulation tissue present. That's more for the venous ulcer because your granulation tissue is showing that there's healing going on and you need blood flow. You need a good blood flow to have healing. So your fast healing granulation is more with your venous ulcers because your venous ulcers has so much blood flow. It has like a bunch of blood pooling, even if it is like maybe like older blood, as opposed to an arterial ulcer which doesn't even have good blood flow. And I'll post a little table done with this. So yeah, the diagnostic, the main one that's really can be used. So your angiogram in general is going to be your gold standard. Your brachial index is also going to be something that is going to be good to be able to tell. With the basic idea being that you're supposed to have more pressure going to legs because it's farther down, it's harder to get there, as opposed to your arms. But uh, if you have PAD, then that person's gonna have less blood pressure going towards the legs than someone that doesn't have PAD. So their index is basically just a ratio of their I don't know which one goes first in terms of the ratio, but it's basically a ratio of your ankle and your brachial blood pressures, and then seeing that ratio. And someone with PAD is going to have, I believe, is exactly, yeah, it's like a specific thing. I don't think you guys really too much on that. Just understand that it is used because I know there is like some specific stuff like yeah, less than 0.9 would indicate PAD. And there's like different stages of how moderate, how mild it is. But it's basically your ankle systolic over your brachial systolic. And yeah, like I mentioned, no, yeah, it's someone with PAD would be less than 0.9. So again, kind of like what I was saying, you would normally have your it's ankle over it's your ankle, just like the name implies, it's ankle systolic over brachial systolic. So so normally, like I mentioned, your legs are gonna have higher blood pressure because it needs to get down there, or to get down there, so it's gonna have a higher pressure to make it all work. But someone with PAD who's having issues getting their blood flow down there, if you imagine like your bottom number staying the same, make it a constant number. If you have like let's say both, just to simplify things, let's say a normal person has 1/1 something. Someone with PAD would have harder time getting blood flow to the legs, so their ankle blood pressure would be lower. So let's say it would be like half of that, so 0.5/1, which is just 0.5. So you can see someone that has worse pressure to the legs is going to have a lower number than one. Does that make sense? That's like super simplified, but that's kind of the basic idea behind it. Your legs are supposed to have more pressure, but if you have PAD, then you're not getting good pressure there, and so your ratio would be less than one. Like I said here, like a lower number, less than 0.9 would indicate. So let's see, hold it down. And I don't think they really go really hard on like you need to know how to calculate it, but again, they changed some questions, so I don't know if they're gonna decide randomly that this time they're gonna care about it. I think just understanding why this is like effective for calculating or for being able to see um how it is, then I think that should be good enough. As long as I think you know that yes, this person we need to check this person's ankle brachial index after you like let's say they come in and you see that they have um like arterial ulcers, but they don't have a history because like, they haven't come into the hospital in like 30 years or something. And then it might be like, okay, we need to alert the doctor, like, hey, they have these ulcers. Maybe they should get like a angiogram, see how the blood flow is going, ankle brachial index to see if they could diagnose them with like PED, do some stress tests, see if they have claudication and stuff. If they already had the ulcers, they're probably a later stage, um, stuff like that. And you'd want to, if someone has an ulcer, they're at risk for a few things like infections and necrosis, gangrene. They might have to get an amputation or something, depending on how bad it is. Oh, but there's also other different things they can do, such as like maybe doing like a stent in one of the um, more like outflow arteries. Yeah, that's kind of the idea there. There's like a few other things that they mentioned in passing by that can be done for stuff like this. So we talked about that it's caused by atherosclerosis. So there's this thing called like an atherectomy. Um, kind of like putting a catheter in there and has like like a little rotation thing that kind of like imagine like cutting through the fat plaque buildup. Let's see. Oh, this one's better. Yeah, you can kind of see how it'd be like a little catheter with like a little spinning thing, and the little spinning thing kind of like breaks down, like kind of shaves out some of the plaque buildup. Good. You guys kind of see that? You guys get the idea behind it? Yeah. Basically, if like that atherosclerosis with like stable plaque, that's causing some ischemia. The catheter with like a little rotation thing is gonna kind of shave it off, get rid of it so that the vein has or the vessel has more room to pass blood, perfuse and stuff. They could also place a stent, like they can do intervention to place a stent, kind of open it up. All these different things they could do. They could do it's called a endarterectomy. They could like physically go in and like cut it off, like do an incision and cut off the plaque, stuff like that. But this would be more for like maybe like an acute case where like someone like has like maybe one of their legs which is like cold cyanosis. There's like clearly like some sort of clot happening or some sort of occlusion, like total occlusion in their leg happening. I don't think they would probably do this if it's like too chronic, if it's chronic. Um, yeah, there's like a lot of different things that I think they barely brushed on, but they exist. And there's one more. I think there's a thrombectomy. There's more like for clot. Where they will like go in and put a stent and see like little stent here. Um, but yeah, that's just for diagnosis. Any questions on this? Makes sense why this is the way this is used. An angiogram is just going to be a way to see how the blood flow is. So it makes sense that if you have issues with blood flow, we're going to do the test that sees how good your blood flow is. Mm, mm, mm. So I'll put T, I guess. That's what I just talked about. So for vascular PCI, this is something they also do for like an MI, they do PCI. Well, I guess this one is PCI with coronary, so this is PVI, percutaneous vascular intervention. So we can have angioplasty, place stents, thoracotomy, about mm, 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 mm. bypass so that it gets more blood, and the endarterectomy. We talked about, which would be like going in and getting rid of the plaque through invasive procedure. There's also amputation, which is possible if it gets really, really bad, where we can't really save the leg and we have to amputate it before necrosis. If you can't save the leg, it's going to start necrosing and then infection and then all this stuff. At the end of the day, it ends up being more beneficial to just get rid of it. That's a possible thing. Maybe treatment's not the best because I have an amputation section. Says is ABI different from segmental systolic pressure? I think it's yeah. So there is two different types, and I think your focus should be mostly on the ABI. But yeah, there is technically a difference. Your segmental systolic blood pressure, I believe, is kind of goes through a bit more. Like it's checking the blood pressures of different, like multiple different areas, the thigh, the above, below the knee, the arm, and that's kind of used to see if there's any like difference in like the checking out the difference in blood pressure, seeing if there's any obstruction, constriction. Um, uh, so there is such thing as like like an inflow versus outflow type of PAD, but we don't need to know that. Your main one should just be think about the ABI more than the other ones I say. Yeah, technically the segmental is for inflow and ABI is for outflow. Inflow meaning that um, the issues kind of happening more like at the start of the artery, like before it, maybe towards the core a little bit more. Not so much the core of the heart, but like kind of like lower groin area where your femoral is starting to like diverge into the legs, more like the inflow because it's having that issue kind of like in before it gets all the way out to the groin. But again, it's like extra information. Does Aaron says would educating patient to walk until they experience pain, then rest and then resume health perfusion? Yeah, I think so. That'd be something we can do for education. So let's go ahead and positioning here, and then we have build tolerance mentioned until experience pain, and then rest and time tolerance. Over time, they will build more tolerance. They'll be able to walk and make yeah, just more tolerant so they can walk around more. They're not just like walking steps and then um, kind of being unable to do anything. There's no heat packs. I think for that one, you don't want like really high heat. I think some is a, I think it's just avoid direct application of heat. But you can have, as long as it's not like unmonitored, but it's something they mentioned. So you can do avoid direct not due to the sensitivity to administrative, but we don't want to just leave something that's like hot on them. They might not notice. They might not be able to tell that it's too hot. That's kind of like the thing. So like a warm compress is fine, but like a full on heat pack is probably not good. A warm compress is fine, but not so much like a full on heat pack or something. Because I remember that heat can be good. It's just here it's because they might not be able to tell if it's too hot and it might cause damage to the limb. heat overall, like the warm compressed can help with blood flow because heat improves perfusion, improves making things a little more. It increases the blood flow, just like how more inflammation, like it causes inflammation, causes more blood flow. Can be good because that's part of the problem. So kind of like in contrast, you also want to avoid vasoconstricts. So I guess what else vasoconstricts that they might want to avoid in their daily life? Um, sure, like I can see that. What else? Don't say. So nicotine. Remember, nicotine is a vasoconstrictor. So we want to avoid nicotine. What else? What's a common thing that you guys might be doing right now? Drinking. What I'm doing right now. Yeah. I have to avoid caffeine because that's also a vasoconstrictor. And if possible, try to minimize stress, although that's easier said than done. So again, you can see that a lot of these, especially these three, kind of go very similar to what your hypertension, atherosclerosis stuff was, similar stuff. Okay. So medications. So there's just like a few, and I think, and you don't have to be a pharmacist, but some of the main medications with arterial, kind of how we were talking about some of your big risk factors, some of your biggest consequences can include a stroke, can include an MI. So if you guys remember from um, earlier classes, or even maybe the hypertension chapter, what can be good to prevent strokes and MIs someone can take? Yeah. Let's, what else? Anticoagulants. Hmm. TPA wouldn't be something that's prescribed to someone to take daily, but yes, we can do TPA for them if they're having an active clot. Yeah, they want to have vasodilators because they're atherosclerotic, so they'll have issues with blood pressure and stuff. Um, it might also be on like beta blood pressure kind of goes with. Can anyone? What are some? Yeah, she did mention Trento, which is exactly uh, something increases blood flow, helps to reduce platelet aggregation. So what's an example of an antiplatelet? Darren said ASA, aspirin. Yeah, decreased viscosity and stuff. What's another example of an antiplatelet? Yeah, lab. Oh, what about some anticoagulants? Aliquis for sure. Aliquis is now more common than Coumadin, but they go with Coumadin a lot. Levinox can be one. I don't think they'd be usually. They're usually going to be on Aliquis. Coumadin. Levinox probably in the hospital. They might be on it. Can also be on like with an active clot. Let's see, active clot. One with an active clot can be on a heparin IV drip. Can be on RTPA or PI, the percutaneous vascular or PVI, percutaneous vascular intervention. And then they do some of the interventions we talked about if they're having like an active clot. Place a stent, balloon angioplasty. And yeah. So you guys should know this, I believe. If someone is how does heparin help a clot? What's its mode of action? Peru? Is that so? I guess maybe more simplified. What's it doing to the clot? Do you guys agree with Caleb that it's a clot buster? Okay. So this is a misconception here. Yeah, Fidel's right. So this is not a clot buster. Your heparin is not going to dissolve. People say blood thinners don't dissolve clots either. Um, it's kind of just a simplified term, just like how people call diuretics water pills to the patient, but it doesn't really, like, the name doesn't really make like sense when you look at it pharmacologically. But so heparin drip is just going to prevent the growth, new growth. The idea here with your heparin is like when you're giving it at a hospital, like you're doing it subcute. When you're giving it subcute, it's there to help prevent the formation of like a DVT. But when you're giving someone has an active clot, then the IV drip is going to help to prevent the continued growth. Yes, and from new ones from forming. So we're going to prevent that thing from growing. And then the RTPA, this is your clot bust. Okay. So heparin is not clot bust. It just prevents the continued growth. And because they take this PO, they're also PO. Levinox more likely, I think. But again, this was probably most. Okay. And there is a difference between the antiplatelets and the anticoagulants. I think for now, what do you monitor for the antiplatelets? Kind of in the name. Mm. A monitor for the platelets. When would you hold it? I'll say, yeah, less than 100. So we know that our normal range is technically low end, like about 150. But the time when like we're really worried about it is more like when it reaches under 100. Um, yeah, under 100, remember when you think about you can have like HIT, for example. So even though heparin, I guess we'll talk about it. What do you monitor with heparin? What values do you monitor? Yeah, your PTT, APTT, all of that. So that's how that one gets monitored. What about Coumadin and Eliquis? This one's gonna be, yeah. your PT, INR, and also your platelets. Honestly, for both, you'll probably do platelets as well, because you can have HIT. If you remember HIT, that's heparin-induced thrombocytopenia. So, and typically, actually, with the subacute heparin, they only really monitor platelets. It's not until you do an IV drip that they'll monitor the PTT. But yeah, you'd look at both for this PTT, PTINR, and all this other stuff. And there is a bigger difference between the antiplatelets and anticoagulants, but it's extra information that for now is much. Um, the antiplatelets are going to be a bit better for arterial clots, while the anticoagulants are going to be better for venous clots for very complicated reasons, more complicated reasons that you don't need. It's above your pay grade. So we're not going to worry about it, but that's why the antiplatelets don't really show up as much for like DVT prophylaxis. Um, but you'll see like 81 milligram aspirin for someone with a risk of stroke. But if someone has a risk for DVT, you'll see these instead, heparin. Right? Does that align with what you guys see as well? Someone with like a history of a pulmonary embolism, um, they'll be on Eliquis or Coumadin, whatever. And someone with like a risk of stroke probably on aspirin, and they might, depending on what they have, they might also be on one of these two, but they'll probably see aspirin. Okay. You can see both. Like for example, like a lot of the people that you'll see at the hospital probably have multiple things going on. So you'll see both. You'll probably see both on a lot of people. Um, but you can definitely have someone that had a pulmonary embolism, is just on Eliquis, doesn't have aspirin. A lot of the perfusion people might be on both, but sometimes you'll just see one or the other, or you'll see, again, it depends on the situation. So DVT, pulmonary embolism, you'll see Eliquis. People who are at risk of stroke and MI will be on aspirin. Again, it's like extra info that's not necessary, but just kind of fun. But if you wondered why he's like, I guess if you've wondered why they don't give aspirin for like a DVT prophylaxis or something, or you're wondering why it's always like Lovenox, heparin, also Lovenox and heparin are going to be faster acting. These take anyway. It's just extra info. I'm just pumping information. Okay. Any other questions on PAD? Move on to peripheral venous. Okay. We're pretty close to like an hour. So it seems like there's no question. So how would you guys define this one? So talk about PAD defined by the lack of blood flow to the lower extremity. So what would you think about for pulling of blood? So kind of in the name, so venous insufficiency, your veins are there to get the blood back up to the heart. So you're gonna have this issue because your veins just are not doing their job as well as they could be. You'll have pooling of blood in the veins. Yeah, it can come with things like with the varicose veins, risk of DVT. All right. So, what are some signs and symptoms? How does it really show? Have all this. Hmm? Yeah, we mentioned this before. If you have blood. Yeah, so warm. So I guess something that could be mentioned, or we can mention here, is that in PAD you have cold legs because the blood isn't going here, but here you have your blood flow is still there, so it'll be warm as compared to the PAD. What else do we think? Do you guys think? Technically, yeah, just it wouldn't be the pendant ruber. So ruber is the color of to make it a little confusing. I'll probably call it like a red brown discoloration of leg. That's from the blood pooling. Technically, it is ruber, but don't want to confuse people because they'll see word ruber probably used a bit more often in the full phrase like dependent ruber when we're talking about PAD. Cramping. I don't think it's much with this one. I mean, if you have a DVT, that is dermatitis. Yeah, that's kind of what this inflammation of the inflammation of the skin from things. What else can you guys see? If you have aching and cramping, what do you suspect? Someone that has all this stuff pooling in their legs.
A DVT.
Yeah, so cramping. They can also say it's like a unilateral, it could be unilateral like what, swelling, like red calf, painful red calf. Okay. Here, the DVT kind of already. In the calf could be in the groin, sudden unilateral swelling. You want to compare to the other leg, be warm, you can have edema. Okay. Okay, so what are some things you would want to treat? Or like, how would you, when someone has a DVT, what are things you want to do, things you want to avoid? Okay, you're definitely not massaging them. Why are we not massaging them? Yeah, we're also not. Why are we not doing these things? It's like a, yeah, we don't want to send the clot back. Elevated here, you might dislodge. So, yeah, we're on DVT right now. Yeah, sorry, confusing. Do not massage. Yeah, because you guys don't want to send the clock up there. You don't want to help. You're basically helping to dislodge them. So in that situation, you're not going to want to massage. You're not going to want to. move, honestly. So when it's active, when you have an active DVT, then you don't want to do these. You want to do these things for someone to prevent a DVT, but once they actually have it, then you wanna basically do the opposite almost, because then at that point, you're not just like normally you want to massage to try to get the pooling back up. You want to elevate to get the pooling back up. You want to ambulate to help with the pooling. But then when they actually have a clot, those techniques that are there to get the blood back to the heart can also help the clot go back to the heart. So that's why we don't want to do that. So when they have an active DVT, what do you want to assess? What's like your priority assessment? Some of your priorities is basically your perfusion and stuff. What else? What's another concept that's like a concept like that you would consider being important? Because what can DVT lead into, like we were talking? Because it can lead to the pulmonary embolism. So pulmonary embolism can have that low SATO2. Uh, Patients gonna feel like they can't breathe, and they can cough out blood. Others, yeah, oxygenation, because we said if that DVT does get dislodged, they can get stuck in the lungs and lots of issues. Okay, so these are probably like the main things. Anything else you guys are thinking about? You guys would like to add, or do we check the location with the dog? Mm.
Diego, can they get a fat embolism too?
Yeah, yeah, you can get a fat embolism. A fat embolism will lead to a pulmonary embolism. I guess think of a fat embolism. I'm not thinking so much of a DVT, but it's like another thing that can lead to a PE. I think the fat embolisms are more characteristic of like a long bone fracture. Um, and then you have like the fat embolism, the level of consciousness for sure. Kind of goes with their perfusion, some pulses, level of consciousness. Um, it's kind of under education. You guys already mentioned this. You want to elevate the legs. This is just pure education for peripheral venous disease. So we've moved on from DVT, and now we're kind of almost doing the opposite. How do we prevent DVT? Because that's kind of like your main complication with one of your main complications. But then how do we do what do we do to prevent it? Kind of like so if there's like three E's, there's elevation. I think this was in your PowerPoint. I guess I don't need this part because it's already kind of there. Related to that kind of goes exercise. Yeah, SEDs are good. And the three E's that they give in class is like elastic compression. Like compression hose, SED. Massages are good when you're preventing them. So this is like for prevention. Yeah, so your anticoagulants are good. Mine goes with medication. Just kind of anticoagulants. Levinox or in subacute. Okay. Anything else you guys want to add? Uh, I think this might be like it's kind of old. Yes, Kayla at 139 asked, would you not ambulate as well? What was that in reference to? Sorry. That's kind of what this is. Yeah, that's basically what exercise is. It's just a word that starts with E, so you have three. Or kind of get them moving around and stuff. Um, okay. Any questions on anything so far? Yes, I hear. We talked about it kind of for an IV drip. If for an active DVT, because again, it prevents the growth of prevention of continued growth of the clot. Measure PTT. What's a normal PTT? Anyone remember what their normal value for PTT is? It's like about, I learned it as 25 to 35, but I think in the PowerPoint you guys got 3. But with heparin drip, goal is somewhere around 2 times the norm. So that would mean somewhere around 50, 50 to 80. Yeah, there's the different values depending on where you go, but somewhere around this range. And it actually depends. So in 232, you guys will go over you kind of go over how the heparin drip gets titrated and everything. So it's like a long process. You're doing blood labs to see where their PTT is. There's a specific goal, and the goal is different depending on the condition. So pulmonary embolism can have different goals than an MI or whatever. Mm, so it says above. Mm. It depends. Again, it really depends on what the order and the policy is for the drip. I'm not sure what they told you guys in class about it, if they even went over it, but that's kind of what I have. I guess, yeah, with a heparin drip, the goal is usually somewhere around 2 times, like an expected thing. Mhm. There's also such thing as a ABC filter, like a surgical intervention. It's like something that catches a clot. Put in a filter to catch the clot and remove it. IBC for inferior vena cava. So, something to catch the DVT from someone that has recurrent DVTs. This is your inferior vena cava, so this is the part right before one of the parts right before it manages to go back up to the heart. So it's like a little filter thing that's there to catch and stop some of the like, potential DVT from making it to the lungs. Will never make it there because it has talked about that. And then lastly, with the insufficiency, we have the ulcers. So these are called stasis. Can you guys tell me about these? Yeah, usually it's not going to be a punch out like the other one. What's probably like the number one? That's true. Yeah, typically you're gonna sign of um, is it swollen? Is it wet, dry? Yeah, like weeping, oozing. There's blood pooling, so it's gonna start oozing. It's gonna have more granulation tissue. Maybe edema. So just like how we remember the PAD has no edema, it's gonna be dry and stuff. This one's gonna have weeping, it's gonna be wet, weeping, oozing edema because this one's gonna have more blood flow. So once like the so much swelling, it eventually causes so much pressure on the skin, it just kind of opens up. Yeah, it's gonna be that reddish brown. This type. More things. Is this one painful? Yeah, it's only painful. Definitely compared to the PAD ulcers, they're not going to be as painful. You have granulation, you have tissue, you have some blood flow going on there, so you'll actually it's not going to hurt as much as the ischemia. You have the camera.
Well, I'm reaching over for an orange. So.
I don't think they can see you. Say hi though. Come on.
Oh, your camera's on. Why do you think I can't see me?
Oh, they can see you.
Oh, yeah, that's what I said. That's
How
what
do
I
I undo the? It says hi. I want to see. Oh, there we go.
said. Orange. Hello.
Yeah, she just finished sim. I'm in the student success center. Um, okay. So here I wanted to talk about the general PVD education. It's actually like full on like a slide. I think that's a really good slide to think about. So actually, because this is pretty much, I think you might have even have told you guys, like the slide's important. Right here. It'll blink it. So remember that someone on PVD or someone with PVD, either if they have PAD or insufficiency, all the time they're going to be on anticoagulants, antiplatelets, so they're going to be at a risk for bleeding. So we're going to be assessing for bleeding, protect them for injury. Their IM injections are more likely to cause bleeding. Shaving, we can cause like little micro cuts or bleeding. Soft toothbrushes, because again, soft bristle toothbrushes for bleeding. Make sure we're monitoring their labs. If they're on Coumadin, they have to get their labs drawn every couple of months, I
What
think.
lab?
And yeah, you guys already answered what lab, but again,
Okay.
once you have to make sure you guys really know
I don't know. They already answered it. It's fine.
it.
I didn't know if you asked it already.
Here, have an orange. You guys did great. Not you.
What?
For
Oh,
them.
for them? So who eats?
Wait.
Oh, okay.
You'll have it if you want.
No, I already have.
Okay.
Yeah. So yeah, it does have antidotes on hand. So what? Just in case you guys get asked this, what is the antidote to Coumadin?
Hmm.
Antidote is vitamin. And then for heparin, okay, let's think protamine sulfate. Yeah. Okay, so it comes up. So then, what are some lifestyle modifications for someone with PVD? And again, we just want to think about some of your risk factors and which ones you guys can, like, hey, you can do this, improve yourself.
Improve yourself.
Exercise for sure. Eat better. Diet, exercise can never go wrong. Only no smoking. You can modify the smoking. You can modify no smoking. No smoking.
Less caffeine.
Yeah. No smoking, less caffeine.
Is it PVD right now?
Yeah, just general PVD.
Mm.
If someone's on Coumadin, what education do you think you could do for them?
Watch for bleeding.
Yeah, for sure. If they're on anticoagulants.
Limit vitamin K.
Yeah, so I think actually for the thing about Coumadin is that the way they explained it to you guys is a bit different to the way they explained it to us in 232 when we were like re looking at it, where they tell you guys like teach them to avoid it.
No, I
And
said limited.
they say limited?
I think
Are you
so.
sure?
Because I just saw two people put the same
Mhm.
thing too. And I remember learning it as
All right.
limit.
Well,
You
even
still
way
need it.
you still need it.
Still need
But
it.
either then, I think the way they've been saying now is for Coumadin, keep it consistent.
Ooh, consistent.
Yeah.
I
So
forgot
they use
about that.
consistent instead of just limit.
Okay, yeah.
Vitamin D. Keep
Consistency.
it consistent. So in other words, if you are a salad guy or a girl, salad gal,
Salad girls.
you can have your salad, just keep it consistent how often you're eating it. Don't just I guess eat like 5 pounds of salad one random day for some reason.
Pop off.
Yeah. And health promotion, I have some stuff here, but honestly, I'm looking at it, it's pretty much the same.
Wait.
Copy paste. Yeah, it's like lose weight if you're obese. Compression stockings are good. Elevate the legs a certain amount of time. Also, I
Wait,
think
did you guys go over PAD yet?
this we're actually done, except for amputation.
Oh. Oh, fun amputation.
Yep.
Oh wow, you guys really are.
Yep. Here's some extra
Wow.
pictures. You want to compare?
Well, that's cool.
Yeah.
I like it. Because yeah, it's kind of hard sometimes to tell the difference between like that's why I keep emphasizing the compare and contrast chart because I feel like at this point on there's a lot of it where you have conditions that are kind of similar like diverticulitis and then you have diverticulosis, UC, and then Crohn's. Now you have PVD, which is like general or like let's just say venous insufficiency in the arterial. So it's always good to have like a compare and contrast of that and the wounds that it presents with too if you haven't gone over
Yeah,
like
we just went over it.
well no like
Mhm.
in just saying it
Oh yeah, yeah,
saying compare and contrast
yeah.
okay
But yeah, so here's a little chart. It's gonna have difference between arterial ulcer, venous ulcer, their locations, the way the pain is like, the depth, typical depth, the shape they look like. And here one for artificial versus venous insufficiency, like a quick and dirty compare and contrast, where that's helpful. Guys. And then now we can talk about amputation. Let's cut some stuff off.
oh
You know,
I just saw him in the parking lot.
Oh, you saw him in the parking
I
lot?
did.
Is he in here though?
No, I was about to call him out for it.
Yeah,
And Mary.
is she not here?
No,
Mm-mm-mm.
I saw both of them.
Oh, Zach and Mary sitting at tree house. Let's see.
Devious. This is recorded too.
Oh yeah. Yeah, so let's talk about amputation. So management of amputation, assessment, all that stuff. So what are some things you want to manage with your amputation? So obviously someone just got amputated. What are some things that's important? Hmm?
All right, when we went to first semester skills lab, I helped somebody crack the stump.
Oh,
You saw it.
oh yeah.
Phantom limb pain. How do you
Yeah.
manage that?
How do you manage? Yeah, it's a fancy.
I think after that, I think my girl Rosemary has something to say. I saw her unmute.
Mm-hmm.
Educate about, okay, so that it's a thing that can happen. How do I treat the
Yeah, how do you
phantom
treat
pain?
them? Like you can't you tell them it's all in your head,
What
but
kind of
it's
pain
it's
meds are you
yeah.
giving?
Some good one for some. What kind of pain?
Specific.
What kind of pain is what kind of
Gabapentin.
yeah?
There you go.
What kind of pain is it? How would you like out of all the types you have, your somatic and your like all that other yeah, it's a neuropathic type of pain.
God, I was like,
So remember that a lot of your neuropathic pain is treated with like your anticonvulsant. So Neurontin is a good one.
so your gabapentin.
Yeah, gabapentin.
That is gabapentin. That's why I was like, wait, that is cool beans.
Cool.
That was the one specifically listed too. And
Yeah.
IV infusions. Oh wait, no, that's something else. Just kidding. Don't listen to me.
Okay. So how would you want them to be? Like, let's say someone got amputated, they got their little cute little stump, their stump stuck on. Well, I saw it. It was cute.
Would you describe that? Go on.
Like a little frilly sock. Yeah. What would you want them to do with that? How would you like it elevated? Would you like them to do movement with it?
How do you manage the stump?
Yeah, you want to exercise it.
Someone said elevate.
Mm, I think I've seen people with the stumps be told that. Yeah, exercise with prone positions.
Yeah, prone is kind of a strange position. So why are you putting them prone and what are they doing while they're prone?
Hopefully, you guys can hear
Oh, hello. Stumps flat.
stumps. Yeah.
Sorry. I mean, yeah, you push them down.
Stomp with the stump. Stomp with. I say the way to remember it.
Never said that.
I always say this.
Don't lie.
I just came up with it like a minute ago.
I guess actually that's actually a really good way to remember that. Stump with the stump, so pushing it flat. I
Yeah,
guess, yeah,
yeah.
yeah.
And to try to avoid like contractures or shorting of the muscle and stuff. You could use psychosocial if that's what you're into.
I don't know how to spell that. I think that's right.
That sounds right.
That looked
That
right.
looks right. All right. What are some assessments you want to do? Someone just got amputation done. Perfusion. How would you assess their CMS? What pulse are you feeling for? Which one's that? Do you remember which pulse would you feel for on a little stumpy boy?
I was gonna say it kind of depends on where your amputation is.
That's true.
So that's a loaded question.
That is a little.
Because I was like, if it's below the knee, your
Mhm.
next closest pulse is what?
Yeah, if it's below the knee, what's your closest pulse? I usually see below the knee.
Below the knee is preferred because you can
Mhm.
fit a prosthesis better.
Mhm.
Above the knee is for emergencies, pretty much only.
Yeah, the little,
Sublidial. Pop off, queen.
yeah.
Little-
You want me to put the queen
I
thing?
do.
Alright,
Why do you not have it like immediately?
does I have to search?
That means you're not using it enough. You spell queen wrong. No, it's crown. If you look
Oh.
up crown.
You led me astray.
It's the same thing.
There you go.
There you go.
Queen.
But yeah, so that's kind of a loaded question because it depends on where your amputation is. If it's above the knee, I would probably say, where is femoral? It's like right in the back.
It's more like right here.
Oh, up there, yeah.
Yeah,
That would
so-
probably be your next,
Yeah.
your most distal at that point if it's AKA, there we go. I was like,
What
solid.
else? Yeah, what else would you guys do? We kind of already talked about pain, so yeah, let's see. They have pain. What else is something that can happen? You just had a surgery, man's lost a limb.
Infection, watch out.
Yeah, infection for sure. There's like another one as well. It kind of goes with perfusion, so you're also checking to see if they're necrosed or anything. Pulses, separate necrosis. That can happen. That can have you can have someone with like really bad perfusion, diabetes.
Oh, that's my uncle.
Yeah,
They had to
and
cut more.
yeah, you have to cut more, and then
Yeah.
it's like your below the knee amputation becomes above the knee.
Well, he's lucky. He still has below the knee.
Mm,
For now. Bleeding, okay.
for sure.
We just cut somebody, yeah, yeah. Bleeding.
Okay, that's
Blind.
pretty good. Huh?
I was like blind. I'm trying to see.
You're blind.
Oh no, it's just the screen is small.
Huh. Wait, wrong way.
Oh, it's like, oh,
Meow.
oh, it's like an egghead. Don't do this, please. There.
Mr. Eggman.
Eggman.
So post-op care, and then we're gonna go over complications, and I think we're done. Oh, and education, I guess. Kind of goes with. Yeah, you guys kind of already covered a lot.
So your post-op care is mainly your
Yeah, your post-op care is kind of yours. I guess you guys already covered.
Oh, how often surgical dressing change should occur?
Sure. How often should you change your dressing? You're gonna assess the dress.
Gross, sanguinous, so whatever.
How often should you change it according to the note? According to your guys's according to Iggy. You don't if you don't know the number, just feel the vibe. What's the vibe tell you?
I did that on the last questions. When people were going off vibes, and it was actually really good.
Yeah, good.
Yeah, that's funny.
Yeah, go off the vibes, guys. The vibe. How often?
2, 4, vibe within 24 hours. I was trying to
That's
figure
actually
out.
right, yeah.
I was trying to figure out what ants was because it says 2?-4, and I was like, oh, I don't know what it meant.
Maybe like 2 to 4 hours. I don't know. 2 to
I'm
4
so
days. I don't know.
sorry.
But the number 2 and 4 make 24 in her.
So with the wind.
It's a weird.
The wind.
Yeah. Here we go.
Gonna give one to Anne too.
We'll give her the nail care emoji. Okay, I lost my.
Okay.
Okay. Yeah, pretty much. You're gonna assess your dressing, change it PRN or every 24 hours according to this. Yeah. So as always, again, we're gonna assess for a sudden changing condition. So if something happens, their pulse is like 2+, and then it's like, oh, I can barely feel it, and
Oh, it's gone.
yeah, it's like, oh, it's starting to look a little bit more bluish
Or pale.
or pale. Yeah.
But you're 6, 7 Ps.
Remember your 7 Ps. You can have compartments in yours.
You could.
Just
Compartment, the Ps basically go off of poor perfusion. It's a
perfusion,
lack
yeah.
of perfusion.
Mhm.
So they'll show up when you have a lack of perfusion. So
Yeah. When in doubt, and there's something perfusion based or
CMS.
CMS, pretty much.
Yeah.
Much what you do.
What was the question?
What was the question?
I don't know.
I had a question.
I don't know. I don't know if you had one or not. I'm asking you.
Okay. So what's your big complication? I know. Or at least that I guess is somewhere in your guys' lecture.
Mm.
Can you repeat that?
Yeah, what's like a complication that was in your guys' lecture for post-op, like in the post-op scenario, kind of has to go with issues with perfusion. Like a kind of, yeah, but basically a clot, some sort of occlusion, some sort of clot occlusion.
Infection is one.
Yeah, infection for sure. I've kind of already talked. Yeah, occlusion and some of that goes with it is like a decreased pulse, acute pain, ischemia, paresthesia. So you see how all these keep seeing the same thing, keep seeing the same. You guys keep seeing like the same symptoms for yeah. If you have a acute change in CMS, that's when you call rapid, call the doctor. It could be an occlusion. We might have to do a thrombectomy, get rid of the clot. Um, do like our RTPA and stuff. Uh, yeah. So some education we kind of talked about, kind of explain the complications, signs and symptoms. So tell them what it's like to have occlusion, which is very similar to that compartment syndrome, basically for CMS. That if they start to feel some of it, then they can alert you with your call light because you're not going to be on them all day because you have like a billion things to do. Um, Something on prosthesis, maybe you have it, rehab is another prosthesis. Pretty much it. Mobility goal, I like that actually. Really good.
Ooh,
I like that. You're getting the clean.
yay.
Yeah, that's pretty much it for PVD. If you guys have any questions. So I gave you guys this chart. I think that's gonna be really big. Or get into this risk factors are always very similar for a lot of your perfusion-based stuff. There's extra information on ulcers in the actual written part, but then there's the basic down and dirty in here. Amputations we talked about there. This is another good picture that Alexis did, so that should help a lot as well.
Oh, that's from Nurse in the Making, I think.
Nurse in the making.
Nurse in the Making, but that's saying her.
Oh yeah, nurse in the making.
Yeah, I had a lot of her bundle. My girl, She was pretty good for a lot of stuff too, like very like picture stuff, like or like one page summaries. Really good with that kind of stuff. I have the bundle
Nice.
too. Yeah, thanks.
Yeah. Any other questions, guys? Yeah. Yeah, we had enough. We had a good enough time. Honestly, we might have been able to sneak ortho in because, well, actually, there's some. I feel like ortho is a lot of it is just CMS stuff. So I just like ortho. Just think about CMS.
6 Ps.
Yeah, like 6Ps, your compartment syndromes, your pretty much
Yeah.
just ortho. When in doubt, ortho is CMS. The main things I think is like maybe understanding osteoarthritis, um, osteoarthritis, compartment syndrome, um, what was that?
Total hip arthroplasty.
Yeah, the total hip arthroplasty, your hip
And the knee.
precautions. Whenever you're in doubt, though, it's the 6Ps.
Yeah, because I mean, think about it. If you're doing anything with your limb, it's like, well, like for the hip one, if you dislocate it, it's gonna turn pale. It's gonna be blue eventually. It's gonna have the poikilothermia because we're cutting off the femoral artery. We're cutting off our blood supply down there if it's dislocated. So yeah,
Yeah.
fun stuff. Love that.
All right, I'm gonna give you guys the PDF, and the ortho on Sunday should be relative quick. It shouldn't take. Again, a lot of it is review. There's some other stuff like on spinal fusion. I don't think that's as big of a focus. I think much.
Things have changed up.
Yeah, things have changed, so who knows? But it's the same PowerPoint at least. So kind of quickly go over it, I guess. But of course, and just because it's not in the tutoring session doesn't necessarily mean it won't be tested on or anything. We don't
give
yeah.
the disclosure.
Yeah, I gotta give the disclosure
You give
because
the
we don't
disclosure.
make the test.
We don't make the test.
Yeah.
We don't make
No, I'm
the
just kidding.
Wait, what?
Say-
Yeah.
no, I'm just kidding.
Well, maybe you'll come back here at one point
Yeah.
as a teacher.
Yeah, they should Ms. Fellows that say they need you need like 5 years experience first.
For clinical assistant.
Oh, clinical
For
assistant.
clinical assistant, and then you work your way up.
Yeah.
In any case.
Yeah, there's your guys' outline. And I'm gonna take a look at what I have already prepped for ortho. Because maybe I'll see if I have pictures for you guys or comparison charts. I don't think as much comparison charts just because it's just like stuff. And then I'm doing thyroid and gallbladder on Tuesday. I have sim on Friday, so I'm gonna do it on Tuesday for you guys.
I'm taking the appointments on Friday from at 12:30.
Yeah,
That's me.
yeah, we're switching spots on that. Of course,
I'm
it's
gonna
all.
wear a man bun and I'm gonna grow a beard. I'll just be you.
Oh
Don't
yeah,
worry
I
about
should
it.
buy like those fake beards.
Yeah, and then I'll just give you my hair. Could be me.
I'll
I'll get you a
dye
wig.
my hair blonde.
Queen.
Yeah.
I love that for you.
Yeah. Any questions on anything? Pretty much done. You guys can scatter.
Get her.